Ventilator. It is a medical device used to assist client with their breathing when they are unable to adequately breathe on their own. Classification of ventilator. Before that, we see about the mechanism of normal breathing. This is our anatomy of lung. First, you need to know about two pressures. One is atmospheric pressure, which is about 760 millimeter mercury, and another one is intrapleural pressure, which is about 160 millimeter mercury. In normal breathing, during inspiration, our diaphragm and intercostal muscle will contract. This results in diaphragm goes down and intercostal muscles will expand. This creates more vacuum into our lungs. Actually, there is an on rule. Air moves from high pressure to the lower pressure. High pressure means positive pressure and lower pressure means negative pressure. Due to increased vacuum within our lung, this creates negative pressure, that means lower pressure within our lungs. Oxygen will enter into our lungs, so this negative pressure pulls oxygen from outside to inside. During expiration, diaphragm goes up and intercostal muscles will contract. This leads to increased pressure within our lungs. This will blows out CO2 from lungs passively, whereas inspiration is an active mechanism. In mechanical ventilation, our lung is not exposed to atmosphere, which is connected with endotracheal tube and with ventilator. In this case, we are pushing oxygen into airways. This pushing of oxygen will opens the alveolus. This is opposite to the normal respiration. Because in normal breathing, diaphragm will goes up which pulls O2 into our lungs. But in mechanical ventilation, we are pushing positive pressure ventilation or oxygen into our patient's lung. In mechanical ventilation, diaphragm is not contracted to pull the oxygen from outside to inside the lungs. So this is called as positive pressure ventilation. Whereas normal breathing mechanism is called as negative pressure ventilation. The major difference between the normal ventilation and mechanical ventilation is in normal ventilation, diaphragm will contract which helps in pulls oxygen from outside into the inside of the lungs. In contrast, in mechanical ventilation, diaphragm is paralyzed. So we are pushing oxygen inside the lungs. Classification of mechanical ventilation. It is classified into two types. One is negative pressure ventilation and another one is positive pressure ventilation. In negative pressure ventilation, it works exactly like our lung by pulling air inside the our lungs. Example, iron lungs. Nowadays, it is not used commonly. And positive pressure ventilation. As I said before, it works by pushing air into the lungs, either invasively or non-invasively. In invasively, we are using endotracheal tube and tracheostomy tube. In non-invasively, we are using CPAP BiPAP. We will review about this ET tube, TT tube and CPAP BiPAP in another upcoming video in detail. Modes of ventilator. There are various modes of ventilator is there, but in this video I will explain three important modes. First one is controlled mode ventilation, second one is assisted control mode, and third one is synchronized intermittent mandatory ventilation. Before discussing in detail about modes, we see about some important ventilator settings. Here are the some important ventilator settings such as tidal volume, respiratory rate, FiO2, inspiration to expiration ratio, PIP, blah blah blah. Sorry, just kidding. Okay, first tidal volume refers to the volume of air that is inhaled and exhaled from the lungs during normal breathing. The normal volume is range between 6 to 8 ml per kg of ideal body weight. If patient is in volume control mode, the delivered tidal volume can be adjusted by increasing or decreasing the volume settings. Whereas if patient is in pressure control mode, the delivered tidal volume can be adjusted by increasing or decreasing the pressure settings. Then respiratory rate. It refers to the number of breaths that taken per 1 minute. Normal respiration rate is between 12 to 20. Then FiO2, fraction of inspired oxygen. It refers to the concentration of O2 that is delivered by the patient. It ranges between 21 to 100%. The important thing here is the FiO2 is expressed in percentage only. When we set FiO2, first we set at increased rate. Example, if first we set about 80%, then we will reduce the FiO2 according to the patient condition from 80 to 40, like that. Then inspiration to expiration ratio. It is a proportion of time spent during inspiration to expiration. The normal inspiration to expiration ratio is 1:2. This means inspiration is 1 second whereas expiration is 2 seconds. Then PEEP, positive end expiratory pressure, is an essentially an amount of positive pressure that is delivered during the expiratory phase of the breathing cycle. It helps to prevent the closure of alveoli during expiration. Usually, we set this at the range of 5 cm H2O. The important thing here is if PEEP is increased, this can lead to hypotension and barotrauma. So, in order to reduce this hypotension barotrauma, we have to set this at the rate of 5 cm H2O. If PEEP is increased means this will reduce the venous return. This leads to hypotension. Note this is a MCQ point. If PEEP is increased means the venous return to the heart will be reduced. This leads to hypotension. Then PIP, peak inspiratory pressure. It is the maximum pressure that is delivered during inspiration. It should be below 30 cm H2O in order to prevent the barotrauma. Then plateau pressure. The pressure applied to the alveoli when the ventilation is finished pushing air into the alveoli and the flow has been stopped. Usually the plateau pressure is maintained less than 30 cm H2O in order to prevent the barotrauma. Actually, this plateau pressure is a measure of lung complaints and is generally considered safest level in order to prevent the barotrauma. It is a measure of lung complaints. Note this, it is an important MCQ point. Okay, if you listen carefully in these last three settings, that are PEEP, PIP and plateau pressure, these three settings are maintained at normal level in order to prevent the barotrauma. So here I have a question for you. Here the answer will be plateau pressure, because in these questions they are asked which is the best estimation of barotrauma. So the answer will be plateau pressure, right? Because it measures the lung complaints, it primarily reflects the complaints of lungs and chest wall. By measuring lung complaints, we can easily assess the risk of barotrauma. Now we see about modes of ventilator in details. First one is controlled mode ventilation. We use this mode when the patient is unable to breathe by themselves. For example, when patient is sedated or when he is paralyzed. So here everything will be controlled by the ventilator machine. Here is a mnemonic to remember this controlled mode ventilation. SIMV mode, right? Here C stands for control and M stands for man. V stands for ventilator. So ventilator controls the man, okay? And next one is assist control mode. It is similar to the control mode ventilation, but the only difference is here there will be a minimal respiratory effect from the patient side. So when the patient tries to take a small breath, it will be immediately sensed by the ventilator and it will provide the breath of a particular volume or pressure or respiratory rate that we are already setted, okay? Here is a mnemonic to remember assist control mode. The mnemonic is ACM. Here A stands for assist and C stands for cycle, that means respiratory cycle, and M stands for machine. Machine assist in respiratory cycle of a person, okay? While selecting this mode, there are two controls. One is volume control and another one is pressure control. Volume control mode. In this, physician will select particular amount of tidal volume. Here, volume of the air will be constant and airway pressure will be vary. Depends upon the patient's lung complaints and airway resistance. Whereas in pressure control mode, the physician will select fixed pressure that should be delivered to the patient. Here the pressure will be constant whereas air volume will be vary. The difference between volume control and pressure control is in volume control mode, the volume of air will be constant, whereas in pressure control mode, the pressure of the air will be constant. The physician will select or choose the appropriate mode for the patient. But how he will choose which mode is appropriate for the patient? And this, you should know about formula for lung complaints. Lung complaints is equal to changes in volume by changes in pressure. That means lung complaints is directly proportional to the volume of air, whereas this lung complaints is inversely proportional to the pressure of air. Okay. So when the lung is stiff or compliance is poor, that means the stretchability of the lung is affected. We can call it as a restrictive lung disease. In these conditions, there is an increased pressure within the lungs noted, because when the stretchability of the lung is affected, our lung does not expand normally. So this will increase the pressure within our lungs because the lung is constricted. That's why conditions like ARDS and pulmonary fibrosis, the airway pressure is crucial. So in this case, we choose pressure control mode over the volume control mode. Whereas in post-operative clients or patient with stable lung mechanics, we need precise control over the tidal volume. So we need to choose volume control mode. Then synchronize intermittent mandatory ventilation. It is also known as weaning mode. This mode is used when there is a spontaneous respiration from patient side. If you look at this graph, the first breath is taken by ventilator and second and third breath is initiated by patient. The ventilator will never help in first two breaths or second or third breaths. However, the fourth breath will be provided by ventilator to meet the adequate respiration rate or adequate tidal volume. So here 50% of effort by patient and 50% of effort will be provided by the ventilator. So these are the three important ventilator mode that I have discussed. Now let's talk about ventilator alarms. Whether NCLEX or NORCET or any other competitive exams, the ventilator related questions, it will come from either high pressure alarm or low pressure alarm. The mnemonic to remember it in easy way. The mnemonic is L and H. Here L stands for low, which means loss of connection, and H stands for high, which means high secretion. In exam, they will give you a situation and ask you to find out whether it is high pressure alarm or low pressure alarm. Let's see about the situations. High pressure alarm. This happens when increased PEEP is noted. When the PEEP will be increased if there is any airway resistance or decreased lung complaints, right? So the situations are increased secretions and kicking of the tube and patient biting tube and increased fluids in the lungs. Then low pressure alarm. This alarm will be off when positive inspiratory pressure falls below the level already we have set it. This indicates any disconnection or leak from the circuit. The reason may be tube disconnection or patient stopped breathing. It gonna be a deadliest reason. Here is what you should do when you hear the high pressure or low pressure alarm. First, assess the patient, then followed by assess the device. The important thing here is do not silence the alarm. This is all about ventilator I wanted to discuss with you guys. If you found this video helpful, share it with your friends who are preparing for examinations. To download flashcards, follow us on WhatsApp channel. The link is provided in the description. Thank you guys. See you in the next one.